Thank you so much. We'll take questions from the audience.
Oh, you have to go.
Yeah, I see it. I can see it here.
Can you see the Zoom question?
Yeah, so we have a couple of questions coming from Zoom. The first is coming from Mohammed Abdael, and the question is, in Fontan with depressed function, do you use sildenafil routinely with any other medications?
Is that for me?
I think that would be a good question for you, Dr. Saraf.
Yeah, so we sort of evaluate, we have a multi-step evaluation process. Our CATS team does very detailed hemodynamic evaluation, and we try to see if any of the pulmonary vasodilator therapies are working or beneficial to the patient, even if they don't have significantly elevated PVRs, if we do see an increase in cardiac output. Without an increase in EDP in these patients, with these agents, we do tend to add the PD5 inhibitors in them and have tried to titrate them slowly over a longer period of time so that they can tolerate them better.
Okay, the second question from the chat is, have you had cases of need for decompression or venting in the atrium in a post-Fontan patient with ECMO, and with that, what approach do you suggest?
I don't know
Matt.
if Dr. Hickey is still on the line, or Dr. Zinn.
Zen.
At least for us, and I talked to our team there. Oh, did the question go away?
No.
We've only had one patient in the past, or in many years, who had, at least from the topic where I gave it, that at a later time had was on ECMO after Fontan. I don't remember specifically if they needed decompression. Our primary approach would be to go to the cath lab and do a balloon atrial septostomy for decompression on ECMO. Another thing we talked about recently, another indication, but haven't done it specifically, you could do an Impella at that stage. But on this physiology here, we would do septostomy.
Yeah, after this question.
I think so. Wait.
Where's that? Or D.
I have two questions regarding aortopulmonary collaterals to the panel. One has to do with intra-op. Do you routinely close or coil these collaterals before transplant to minimize bleeding issues? And two, what is your strategy post-transplant? Do you revisit those if there are any residual collaterals?
I think with our limited experience, haven't had a structured approach in each individual patient. I looked at those patients that we had. They did not require significant coiling of collaterals after and did well, or before and did well after. So unfortunately, I don't have a good or a set answer for us programmatically. I just haven't had that experience yet.
I think it also depends on the stability of the patient and how they're presenting. Oftentimes we have to, even if AP collaterals are addressed in the preoperative period, typically on the first trip to the cath lab for a biopsy after a transplant, we have to address additional collaterals.
And we have had at least two patients where we had to go to the cath lab the next day because there was significant bleeding in the operating room, and to coil and to get rid of collaterals. But I think over time, because as transplanted heart recovers and filling pressures go down, those AP collaterals often improve and get smaller over time, where they don't need to be addressed.
Yeah, we've had some patients, especially those who wait for a long time on the list, have reemergence of collaterals. So we're wondering if you guys have any approach regarding recathing them routinely every 3 to 6 months while on the transplant list, or no?
No, and I think from a support standpoint too, it's all been relatively short, to the point where we haven't had just the need yet or the indication to recath.
From being a cath doc, we tend to usually always pre-cath those patients and close all the collaterals. In the pre-Fontan cath early, we know that they come back very quickly and try to do the pre-Fontan cath 2 weeks before the Fontan. But in these failing Fontan patients who are going for transplant, I don't know whether it's because they're usually not so blue or what, but it seems like the work we do in terms of coiling collaterals tend to stay longer, so that if you do a very aggressive collateral closure in the pre-transplant cast, you do decrease the risk of bleeding in general, but sometimes we've had to come back, as you say, and go on close, especially if you suspect they had a lot of bleeding in the OR or they're high filling pressures.
Looks like we might have time for one more question that I can take from the virtual chat. When PLE turns into when does PLE turn into a heart transplant contraindication? And how do you manage systemic AP collaterals in the heart transplant? So I think we answered the second part of that question. I don't know if Dr. Saraf and Dr. Zinn, if you want to address PLE and heart transplant.
I think we've had some difficult patients that have had PLE, and if we could maintain some degree of control before, we have not had it as a contraindication prior to transplant in the right patient. Otherwise, the patient is a good candidate. We would have a belief that it would be successful in reducing PLE or recovering afterwards.
I think frailty is an important concept here too, seeing how much you can get the patient back to a stable state where they can tolerate the rigors of transplant, and that becomes sort of a subjective decision. Objective from a physician standpoint because we see these patients, but it's a little bit of a gestalt on how stable the patient is and what their frailty index would be.
I think Dr. Feingold nicely showed data that PLE resolves after transplant. I think one of the biggest considerations we take into account is how it could affect preformed antibodies going into transplant and think about monitoring closely afterwards. Any other questions from the audience? All right, thank you to all of our speakers for an excellent session. I think you have a break.